Hi, good evening, good afternoon, or good evening, good morning to some, to guests from other parts of the world. Welcome to today's webinar. Um, Today we're going to talk about the third-party reproductive option, which normally includes donated eggs, sperms, embryos, or gestational carriers. And today we have the honor and pleasure to have Dr. Don Royster from Southern California Center for Reproductive Medicine to join us. He will be covering the IVF part, some of the basics concepts about the third-party reproductive option, and I will be going through the surrogacy and egg donation part. And uh, Dr. Royster joined the SCCRM this past summer, and he's a highly accomplished um, as an Air Force Academy graduate, and he got his civil engineering degree from United States Air Force Academy. Then he went on got his MD from the United Uniform University of Health and Science. Lots of rewards and accomplishments. He's also a fellow of the National Institute of Health. Um, so without further ado, let's welcome Dr. Don Royster.
Hello, and good evening. Thank you for coming and joining us today.
Mhm.
It is a special time when we're trying to help couples and patients try to conceive. That's a struggle that a lot of people deal with within the United States. And it's 10 to 15% of all couples in the United States some form of that goes to say that for those couples that are single, that are in same-sex relationships, that are transgender, we're going to have additional challenges trying to expand their family. We're going to talk about some of those aspects of what that means and what you can do to try to help your chances of. We'll talk about what in vitro fertilization is versus insemination. Have an overview of the surrogacy process and the screening and matching process. Then have some questions and answers that you'll be able to give to me and relations so you can get a clear understanding of kind of what's going on. Dr. Anderson's been here in practice for about 30 years, and when I joined his practice here in Southern California, I was very happy to do so. He has some of the highest pregnancy rates in the country, and I'm so excited to continue that trend and continue to help those couples conceive. Like he said, I spent over 20 years in the United States Air Force and rose to the rank of colonel before retiring last summer, returning to my roots here in Southern California. And so today we're going to talk about what does it mean for a couple that needs a donor or a surrogate, what we might look for in a good donor versus a surrogate, what's the differences between an anonymous versus a directed donor, and what does reciprocal IVF or gestational surrogacy kind of look like. So let me just talk about the birds and the bees here real quick. And so this is kind of health class, 8th grade, going way, way back for some of you. Needless to say, in order to have a baby, you need to have sperm, you need to have eggs, and you need to have a somewhat normal uterine cavity for implantation. If you're trying to do it the old-fashioned way with timed intercourse, you're going to need at least one functional fallopian tube. And for some couples, whether they're heterosexual in a same-sex relationship or single, they're going to have additional challenges because about a third of the time, it can be a male-only factor with infertility. A third of the time, it can be a female-only factor. And a third of the time, it can be a joint factor. So you can imagine if you are in a gay relationship, you're going to have all the sperm you need potentially, but you're not going to have the eggs or the uterus in order to conceive. Just like for those patients that are in same-sex lesbian relationships, you're going to have eggs and uteruses typically that may be functional and useful to try to conceive, but maybe they need a donor sperm, either from a family member or a friend or an anonymous donor. So these are things that are going to have to be kind of considered and taken into account. When we go through that evaluation process, just know that from a female perspective, typically the thing that's going to be the limiting factor is going to be age. Women are born with all the eggs you're ever going to have. Typically, you're going to have some 6 to 7 million even before you're born. By the time you're born, you've lost half of those eggs. And then over the next 12 to 13 years, by the time you have your first menstrual cycle, you're down to about the last 300,000 to 500 eggs. So even though you may only ovulate about 400 times in a lifetime, each month that you ovulate one egg, you may be losing hundreds of thousands of eggs just through normal atresia, normal processes. But of course, there are conditions that you can be born with that may cause you to lose eggs at a more rapid rate than other patients your same age. Or maybe you have severe endometriosis, needed to have surgery and ovarian cystectomy to kind of help with pain and pressure that you had from endometriosis. And that could reduce the ovarian stroma and the ovarian reserves that you may have. You may have had treatments as a young child where you had exposure to radiation or chemotherapeutic agents. Again, those are things that can deplete your egg count even before you're even trying to conceive. And then for those patients that have an intact uterus, maybe you have scar tissue from previous miscarriages or infections. Maybe you have scar tissue from endometriosis. Maybe you had a C-section and have scar tissue. Any number of these things can cause scarring of the uterus that then may prevent you from being able to get pregnant. So the idea is that whether you need a third party or you're in a heterosexual relationship, there are conditions that may necessitate the need for donor egg, donor embryo, or gestational surrogate just because of medical things that have come up, aside from having a single patient, a transgender patient, or a couple that's in the same-sex relationship. And so just understand that for men, we're producing millions of sperm on a daily basis. In our lifetime, we produce over 1 trillion sperm. And so on June 1st, June is Men's Health Month. And on June 1st, if you log into SoCalFertility.com, you can sign up for our free webinar to talk about men infertility and male infertility and some of the causes and treatments of male infertility, other than just buying donor sperm. On the 4th of May, we have Fertility 101, again at 6:30, the first Tuesday of every month. We're going to talk about Fertility 101, and I'll show slides and videos and interactive pictures to discuss what the basic evaluation looks like and what different treatments look like. And so tune in if you want to get more information beyond just what we're talking about tonight when we talk about third-party reproduction. And so for those men, like I was discussing earlier, just because you have normal sexual function, it has no bearing on the sperm count, sperm quality, motility, or morphology. Sometimes just a simple semen analysis test can reveal things that you may not know. And then obviously there's more specialized testing that we can do on that sperm if we have to do hyaluronic binding assays or other testing to see is that sperm viable because you have borderline conditions. And so, like we were saying with third-party reproduction, same-sex couples, transgender couples, single patients are always going to be missing a key element when it comes to having a baby. Again, whether it's an egg, a lack of an egg, a lack of sperm, or the need of a uterus in order to conceive. Now, when we do use a third party, keep in mind that there's going to be FDA regulations on the timing of additional labs that we have to do and quarantine time. So typically, if a gentleman is going to donate sperm to a sister and their wife or to a friend, and it's a directed donor, meaning you're not in a sexually intimate relationship, typically the men have to have labs that show that they're free of infectious diseases within a week of depositing and freezing their sperm. And then typically we quarantine that sperm for 6 months. At the end of 6 months, that man has been tested again to ensure that they don't have HIV, hepatitis B, gonorrhea, chlamydia, or other sexually transmitted infections. And then obviously if they've relinquished legal rights to any offspring from that sperm, then that donor is then deemed adequate without any additional waivers that are needed. But sometimes men will have frozen sperm. And then the other part of it is they have to have a physical exam, again, within that week prior to freezing that sperm to look for any evidence of infections, needle tracks, drug use, things like that. And so for women that are donating eggs, similar process, their labs have to be within a month. Again, physical exam within 6 months of egg donation. And again, have that same legal clearance where they're authorizing release of their donor eggs. Sometimes they could be identified to the offspring of who they are. Other times they may want to protect their identity. Again, those would be up to the donors on what they would want to do regarding that. But if it's an anonymous donation, then all the legal things are pretty much taken care of. We do want psychological screening of the donors to happen as well, because we want them to have legal protections for both the intended parents and for the donors themselves. Because you can imagine, if you are the brother of a sister who's in a same-sex relationship, and you're going to donate sperm so that the wife can conceive and then have your sister, let's say, carry that pregnancy, there are legal implications that you may not anticipate, and psychological implications that you may not think of when that father, that biological father, is both the uncle and the biological father, and may still be involved in that child's life. The vice versa example is true as well. If you have a sister that has a brother that's in a same-sex marriage, and she wants to donate eggs so that the husband can fertilize those eggs and then use a third-party gestational carrier to carry that pregnancy. Again, there's implications both legally and psychologically that we would want to establish and clear up before entering into that type of arrangement. Later on, we'll talk about some of the costs involved with having anonymous donation and surrogacy versus someone that's a family friend or colleague that you know. And some of the costs that are involved can be a little less on the front end if you are using a family or a friend to help you conceive. But that still doesn't negate the need for the medical clearance and the psychological clearance, the legal clearance, and all those other implications that may happen when you're very familiar with the person that you're trying to utilize as your third party. So for those women and those lesbian couples that are trying to conceive, again, depending on her age and the age of who wants to carry the pregnancy, you can have intrauterine insemination with rates as high as about 15%, depending on what kind of medications we're using and depending on the age of the patient that's trying to conceive. You can use a directed donor, or you can use an anonymous donor. And also a slide here quickly to talk about intrauterine insemination, what that means versus in vitro fertilization if IUIs are unsuccessful, or if you need to use IVF for some clinical reason. And so it goes without saying that same-sex gay men have a harder time trying to have their own babies. Out of the 3 required elements, egg, sperm, and uterus, they only have one of those 3 elements. And they can typically utilize both fathers to help try to fertilize eggs. But they're going to need an egg donor and or a surrogate to carry that pregnancy. So if you have a gestational surrogate, that gestational surrogate is a woman who utilizes her eggs and the use of a third party, meaning another man, to fertilize that egg, and that woman carries that pregnancy to term, basically acting as both the gestational carrier and the egg donor. Whereas a gestational carrier is not a biological mother to that offspring. She is just the carrying the pregnancy in the uterus, but we have it used for eggs to help conceive. That's kind of the difference between the two. And so, needless to say, for those men that are having to try to conceive with the use of donor egg and a gestational carrier, there are going to be increased costs to them compared to lesbian couples that are trying to conceive. Because remember, about a third of the time, even for same-sex couples or transgender couples, you're going to have male factor only, female factor only, or a combination of the two. So up to about 50% of infertile couples may have some component of male infertility that may play a role. And so let me just kind of share some of what we look for when we're trying to identify an adequate egg donor. And so men have been able to be sperm donors for over 100 years. But it's only been here in the last 30 or 40 years with the advent of in vitro fertilization that we've been able to utilize the use of donor eggs, where we stimulate a woman's ovaries to produce extra eggs, we retrieve those eggs, and then in a fresh cycle try to inseminate sperm in order to create an embryo, and then either use a fresh embryo transfer or freeze eggs on the front end and then use those eggs at another time in order to conceive, or create those embryos and then freeze those embryos for future use. Needless to say, these women that are egg donors are typically going to be younger, usually in their 20s. If they have proven fertility and have other desirable traits, they may be more sought after. Typically, we wouldn't want an egg donor to donate more than about 5 to 6 times during their lifetime. They got to have no sexually transmitted infections, nor be at high risk of contracting HIV or other sexually transmitted infections. We don't want them having tattoos or piercings that are recent, that may not have used aseptic techniques. And we typically want them to have compensation in compliance with the association, ASRM, the Association of Reproductive Medicine 2000 Ethics Committee, which basically talks about what would be adequate compensation. Because in essence, you're not buying eggs, you're compensating the donor for their time and effort in order to go through that process to donate for eggs. Now, a gestational carrier, like I mentioned before, is someone who carries a pregnancy for others, whereas a gestational surrogate uses her own eggs to carry the pregnancy for another couple. Gestational carriers are typically in good health, less than 40 years old, and they typically have had less than 5 total deliveries and no more than 3 C-sections, body mass index less than 35, and have infectious disease labs and a hysteroscopy within the last year. Hysteroscopy is the testing that we do in order to identify patients that have filling defects or abnormalities on the inside part of the uterus, so that we can normalize that before putting in an embryo. And so for patients who have been a gestational carrier in the past, then we use the protocol that they've had in the past as far as the timing of the progesterone for them to place the embryo in the uterus. About 10 years ago, we identified that about 20 to 30% of patients need more than a standard 5 days of progesterone exposure before having receptivity of the uterus. And in our practice, we've noticed that about 75 to 80% of patients are going to be pregnant after transferring a euploid embryo, meaning an embryo that has a normal number of chromosomes. And for that small percentage of patients that aren't pregnant after the first frozen embryo transfer, we've identified that about 20 to 30% of them needed more time with progesterone, because the window of implantation for that embryo is only about 24 hours. And you can imagine if you need an additional 24 hours of progesterone exposure before embryo transfer, you may have missed it. And so if you are a gestational carrier for the first time, or your intended parent that's looking to use a GC who's never done this before, then we would recommend doing an endometrial receptivity assay test. And that's where we do a mock frozen embryo transfer, give that woman the similar estrogen exposure that we would normally do to prepare the uterus for implantation. And then we give them 5 days of progesterone. And on the 5th day, instead of putting in the embryo, we take a small sample of tissue to look at about 238 different genes and proteins, some of which are upregulated and others that are downregulated. And that will identify the exact timing of when they're receptive to their uterus for embryo implantation. And that can improve pregnancy rates by as much as 15 to 20%. So you can imagine if you already have a 75 to 80% chance of pregnancy going into the cycle, and we can improve that by 10 or 20%, that's a huge improvement. And so for those patients that are GCs, or you want to use a GC that has not had an ERA test or has not had a frozen embryo transfer in the past to have a live birth, then we recommend doing the in vitro receptivity assay. For those patients that have had a normal delivery, they have normal health, we still recommend that we have an office hysteroscopy. And that's a quick test. It takes about 2 to 3 minutes. It's the gold standard for ensuring that the uterine cavity is normal. We place a camera inside the uterus with the use of normal saline to take pictures and make sure there aren't polyps or fibroids, because again, those kind of abnormalities inside the uterus can reduce your chance of pregnancy by up to 40%, and we would want to normalize that before doing any kind of procedures like embryo transfers, because again, those are limited resources. So, intrauterine insemination, which is IUI, versus in vitro fertilization, IVF. Here's a slide that just kind of summarizes both of those quickly. So, intrauterine insemination, we typically want to help a woman superovulate with maybe 3 or 4 mature follicles. Women that are 35 years of age, about 1 in 5 of their eggs, on average, are going to be chromosomally normal. We looked at some 13,000 patients in our practice over a 10-year period to identify how 20-year-olds, about 1 in 3 of their eggs are going to be chromosomally normal. Women in their young 30s, about 1 in 4. Mid-30s, about 1 in 5. When you approach 37, 38, about 1 in 8 of your eggs are going to be chromosomally normal. When women approach 40, only about 1 in 12, meaning if a woman is 40 and she's ovulating each month, maybe only 1 of those eggs are going to be capable of producing a live birth. And obviously, if the timing isn't just right, then they may miss that 1 egg that they ovulated over that 12-month period. And for those women that are 42, only about 1 in 20 of their eggs are going to be chromosomally normal. And so when we're making the decision about who is going to try to embark on intrauterine insemination, we want to take into account the age of that woman and the quality of the eggs that she may have left behind, just because we know that age-related decline in fertility is a real thing and probably the biggest limiting factor for patients trying to use intrauterine insemination. And so in essence, we take oral or injectable medicines, help that woman to try to create extra follicles during the month, and then when that time comes for ovulation, we give them a second medication called HCG to help trigger ovulation about 24 to 36 hours later. And then we take concentrated sperm, either fresh sperm from a partner or a directed donor or an anonymous donor that's already been washed with sperm wash media that washes away the prostaglandins that's in the fluid. The ejaculate itself, about 90% of it is not actual sperm itself. It's fluid from the prostate and the seminal vesicle. So we put it in a centrifuge in order to remove all that excess fluid, and then take a little small catheter with that concentrated sperm to put it right next to the openings of the fallopian tubes. During timed intercourse, there's only a few hundred out of millions of sperm that make it to the fallopian tube to be placed in the tube where fertilization happens. And that's because it has to traverse the vagina, go through the cervical mucus, all the way through the uterus and into the fallopian tube. Intrauterine insemination hopes to put concentrated sperm, millions of sperm, right next to the opening to the fallopian tube, so that instead of just a few dozen or a few hundred sperm making it to the egg, we hope to have hundreds of thousands, if not millions of sperm that are at the egg to help try to penetrate that egg and fertilize it. Again, that gives you about a 10 to 15% chance of pregnancy. IVF is a little different. We use injectable medicines, 1 to 3 shots per day, and we do that so that we can try to create an environment to have 10, 20, or more eggs that develop, a lot more than doing intrauterine insemination, because when we ovulate during an IUI cycle, we can't control how many eggs might be fertilized. Whereas during IVF, we're trying to create an environment to get as many eggs as possible and then surgically remove those eggs. Again, 35 hours after that HCG insemination. And that's done minimally invasive with a transvaginal ultrasound probe, a long needle through the vagina into the ovaries to drain the fluid around that egg. Under the microscope, we look with the laboratory to identify those mature eggs, combine them with sperm in the laboratory, grow them in culture for a week, and then a week later we do a laser biopsy of that embryo to send that tissue off for genetic analysis to identify those embryos that are normal. That's what we typically do in our practice. We don't do fresh embryo transfers. We want to get that genetic information first so that we can do an embryo transfer in the subsequent cycle. Again, here on the 4th of May, if you want to see more details about what intrauterine insemination looks like or IVF looks like, then tune in at SoCalFertility.com to my pre-webinar, 6:30 on Tuesday, coming up here in about 2 weeks, literally 2 weeks from today. So I want to reintroduce my partner here from Patriot Conceptions so that we can discuss more about the intricacies of surrogacy, selecting surrogates, selecting gestational carriers, and the egg donors. And so without further ado, I'll have my partner join us.
Thank you, Dr. Royster. I think the slides here is a little misplaced. Let me see if it's working. Okay. Sorry. The first of all, there's the concept between a lot of people wonder what's the difference between the traditional surrogacy and the gestational surrogacy. Again, I apologize for the misplacement of the picture. Maybe when the slide gets converted to a different format, it gets misplaced. But traditional surrogacy, just like what Dr. Royster, the concept that he introduced, intrauterine insemination or IUI, normally it's done by IUI but the key difference is like in traditional surrogacy, the surrogate's own egg is used during the surrogacy, as opposed to gestational surrogacy. Everything's done by the IVF, so it's either intended parents' own eggs, sperms, or donor eggs or sperms, but it doesn't involve the surrogate's own eggs. That's the first concept, and in California, in the United States, a lot of states actually prohibit the practice of a traditional surrogacy because simply it's just too controversial. When the surrogate's own eggs is involved, technically that's her own babies. Then when the baby's born, she inclined to feel more attached. So it caused a lot of legal hurdle in the past, and that's actually the reason why in the past the state of New York and still nowadays state of Michigan still banned the commercial surrogacy because the controversies it's caused. And fortunately, state of New York just legalized commercial surrogacy this past February. And talking about the surrogacy requirement with us, it's a little bit more stringent compared to our ASRM guideline, is because the various clinics that we work with, and based off the intended parents' recommendation, so we have a little bit more stringent requirements. Normally, the candidate that we select to become a surrogate, they age between 21 and 38. The reason why they gotta be 21 is because we want them to be mature enough to make their own decision. And the ASRM, of course, this is not very arbitrary. If the intended parents really like somebody who's over 38, we would still accept. But in our program, we normally this is more of a stringent requirement that we use when we select the candidates. And there's a body mass index under 30, even though the ASRM recommended 35. Financially stable, we do for our surrogate, when we do the screening process, we do the thorough background check on them, their criminal records, if any, on the county, state, and federal level. We do pull their driving record as well as a soft pull on their credit report. It doesn't affect their credit score at all, but we just want to see if they're financially stable, they don't have any outstanding financial obligation that will impact their decisions. Because for surrogacy or egg donation, financial incentive can be a primary motive, but we don't want that to be the only thing. We want somebody who's passionate, who wants to help, build families, and no non-drug user, non-smoker. That's very, as Dr. Royster explained, it's a very common. Of course, that's some of the common reasons that will cause, miscarriage and just overall not healthy for pregnancy. Own a vehicle. That's That's because she would have various appointments. She would have to drive back and forth between monitoring the clinics and her home. So we require somebody to have a stable vehicle and and a valid driver's license. Surrogacy friendly state, as I just mentioned, the state of New York become the newest state that legalize commercial surrogacy. Right now in the U.S., I think the only three that are still are difficult or challenging to do surrogacy are the state of Michigan, Louisiana, and Nebraska. Other than those three, even though the state law changes, from one to another, but overall they're all legal. In some states we can do well. Later on, I'm get to that part. In some state, you can establish your parentage before the birth of a child. In some other state, you have to do it post birth. And of course, the surrogate got to be a U.S. Legal U.S. citizen or legal aliens, um, willing to. Also, there will be a psychological evaluation. Like I mentioned, we want to evaluate their motives, uh, whether the money is the primary driver, and also there are other aspects. If they live in a good environment, we're going to evaluate their relationship, their stress level, and all that's done by a licensed psychologist. And Dr. Royster also explained that there will be a intensive, physical or health screening before we make a decision on whether she's suitable for surrogacy. There's an FDA required test. She will go into the clinic in person, um, for to do the ultrasound, and also to have the doctor to take a look at her uterus lining, etc. etc. And the surrogacy cost is the biggest part, and it's the biggest concern for egg donation in general, egg donation and the surrogacy cost. Uh, Here we have a very competitive pricing compared to the the current surrogacy market. So in general, it costs you anywhere between 100,000 to 130,000 in the state of California, because it's we have such huge demand in the state of California, and because we're one of the state one of the first states, actually, matter of fact, that have a very comprehensive surrogacy law to protect both intended parents and the surrogate's rights, and also because of the just overall in the state of California, we're very accepting, whether you're gay, straight, regardless of familial status, regardless whether donor eggs or sperms are used in the surrogacy journey. Um, California law allows all this kind of situation, as opposed to some states where gay couples might face difficulties or challenges acquiring their parentage parentage rights. And so how this money was spent, most when the surrogate was screened by a private investigator for their background check, or by nurses to review their medical records, and all sorts of intensive screening, primary psychological and medical, and a behavior review. That's the first chunk of the cost. And second is the legal. Legal normally got broken down into two parts. The first part is the surrogacy contract. The intended parents would have his legal representative to draft out the contract, and the surrogate will be appointed to an independent attorney to review the terms and condition. That's the first part, and the second part is in California we call it PBO, pre-birth court order, to establish the parentage prior to the birth of the surrogate child, um, as well as escrow or trust account management fee. Normally, it's handled by your own attorney, but sometimes you use a professional surrogacy escrow company because there's a large amount of money involved. That's why all the money going to get deposited into a third party trust account or escrow account. And whenever a milestone or a term that's being met or fulfilled by the contract, the fund will be dispersed to the respective parties. Surrogate benefit package. So in addition to the base compensation to compensate the pains and suffering of being a surrogate, there's also some common fees involved, like maternity clothing allowance. They're gonna have to buy some maternity clothing. And when they get to a certain stage of their pregnancy, it's going to be difficult for them to move around. So they're going to have needed somebody to come once a week to clean up their house. Of course, how you design the surrogate benefit package is up to it's between you and the attorney. They can we do have a standard that we recommend, but there's always room for you to discuss with if you want to add something more on top of the standardized package. You can feel free to do so. Everything will be written in the contract, and whenever something happened, the trust account or escrow account will use that as a primary reference to disperse the fund. Surrogate insurance is another one that varies in different situations. What we want to do traditionally is during the open enrollment period, we try to get as many surrogates enrolled under the Affordable Care Act as much as possible, because in that case you can save a lot of money by using the standardized ACA plans, as opposed to if unfortunately that you miss the cutoff, you're going to have to use a specialty insurance. Normally it's backed by Lloyd's of London, but the insurance cost and the medical fee can go and skyrocket. Those bridge policy or special policy can cost you well over $25,000 in everything included. And also after if you intend to have the surrogate to carry twins, normally you would purchase a newborn insurance to cover the surrogates, to cover because when you have a twins, it's more of a higher risk, and the newborn insurance will be recommended. Life insurance for surrogates is also normally in the contract to cover normally $250,000 to $500,000. It sounds a lot, but the monthly premium is actually not that. For the whole year, it's probably only going to be $300 to $400, just in case, God forbid, the surrogate have any, the surrogate lose their life during the journey, and it did happen in the past, even though very rarely. Their families and the rest of their family members can be covered and taken care of. And already went through some of the process. So pretty much we do have they do make appointments to see the data, to see our data. We do have respective surrogates and egg donation pools. And if you, I can do a quick. If you like, if you pay attention to the center of your screen and click on Learn More, that leads to our surrogacy profile page. And if you're interested in any specific surrogate, click on their profile. The page will prompt you to sign up, and once you got vetted by our client relation step, you'll be able to access to their full profile page. And find the ideal surrogate. Like I say, there's a detailed page on our website to have their as much as information is available to you. Their life philosophy. Are they willing to carry twins, singletons, or triplets? They willing to work with the international versus domestic? And how many embryos are they willing to carry at any given time? I know Dr. Royster will say, one will be, because single embryo transfer is the safest, and that's what I recommend. But just in case if you have special needs that you would like them to transfer to, the surrogate would provide an answer to see if they're willing to transfer to. And matching with the surrogate normally it goes very fast. Prior to pandemic and during the pandemic, we use majority of the cases we use Zoom call to connect intended parents and the surrogate. So you kind of you can feel this out yourself whether they're the right candidates for you. Then there's a medical clearance cycle, medical clearance where you will do the blood draw. If you have a partner, they will do the same thing. Psychological evaluation, um, your partners too. Then they will go into the clinic, do the all the required ultrasounds, and the legal process. The first part of the legal contract, they will do so after the clinic clear them legally, and then then they will be continue. Then they will get. Then the clinic will issue FET, or called a frozen embryo transfer calendar. It will specify what type of medication and what duration, what frequency they will use with injectable or oral, or sometimes both, a combination of both. They would use prior and after their transfer. Um, and 10 weeks after the continuous monitoring at the local or a local IVF clinic, they will we call it graduation, and they will go to their normal OBGYN doctor for the remainder of their pregnancies. That's the overview of the surrogate screening and the matching process. And let's see. And by the way, Dr. if you're interested in any of the webinar, Dr. Royster mentioned that there's male health, and there's another one coming up in 2 weeks, and simply you just want to schedule your first consultation with Dr. Royster. I know, and right now, since we just we just started to see the light at the end of the tunnel, but we're still using Zoom for the consultation, and it's at a great discount. If you like to learn more about SCCRM, or you like to schedule a consultation, you can pay attention to the center of your screen and click on Schedule Now. That will redirect you to SCCRM website to schedule a consultation with Dr. Royster, or you can check out their event tab. You go to the menu and the event tab. You will see all the upcoming webinar at the SCCRM. And in a Petri Conception, we do offer surrogate financing, partner with Prosper Health Landing at Salt Lake City, Utah. They will be able to lend out up to $100,000 at a great interest rate. And another way to save money, we do have independent journey options. So pretty much we screen the candidate for you, acquire all the medical records, have the nurse to do all the necessary review to make sure she's suitable, she's ASRM guideline compliant, and if you decided you want to handle the journey by the rest of you, or for the remainder of the journey. So if you want to do an independent journey option, you will save a great deal, and pretty much all the costs majority of the costs will go to the surrogate and the insurance. So you save over $10,000 to $20,000 by doing it independently. Okay, and we just talked about the financing option, and with SCCRM, if your employer work with the progeny, which is the biggest provider of IVF and IUI, they also accepting progeny. And if you're employed by big names like Target, or Blizzard Entertainment, or any other Qualcomm, and in local urban area, they all you probably already got offered the progeny, and very likely SCCRM accept that, and different company have different policies, but majority of them will cover up to 2 cycles. Some go further until you have a baby. So definitely make sure that you check out your employee handbook to see if your employer sponsor the progeny insurance options. And okay, that's it for my option. Thank you for your attention, and Dr. Royce, I do think we have quite a bit of questions in the chat channels here. So what we're gonna do is we're gonna do a brief Q&A session to resolve most of the questions here, and then we're gonna have the moderator to pick the ones from WeChat, YouTube, or Facebook. We're going to pick some of the questions, and we're going to try to answer as many as we can.
Yeah. So how about you guys look at some of those questions? I do want to share some additional information that's come up during the webinar. One of the things that I would like to share with you. Show you something that's important. So back in the day, when we were transferring embryos without the genetic we're oftentimes transferring 1, 2, up to 4 embryos. You might have heard of the Octomom 11 years ago. We had 8 embryos transferred and had all 8 implants and had the first successful live birth at term, year term, of 8 live-born babies. So whether you're the intended parent or the gestational carrier, I want you to keep this in mind. Number one, in our hands, with euploid embryos, if I put in 1 embryo, your chance of pregnancy is 80%. If I put in 2 embryos, the chance of pregnancy is still 80%. Doesn't double, doesn't go up, but what we do is we increase the risk of adverse outcomes for both the intended parent and for that surrogate. Babies are typically going to have a 10-fold risk, 10-fold higher risk of being very small when they're born, being premature, having stillbirth, having malformations, and or having genetic abnormalities that could have been prevented with, which could have been prevented with having just 1 embryo. So that's one of the things that I wanted to kind of focus on, is that for those couples that have been dealing with fertility issues, or you're trying to have all of your babies at one time, you're trying to have 1 pregnancy, 1 surrogate, have your boy, have your girl, just understand that you're going to increase your risk of having a miscarriage and having a stillborn and or having severely handicapped children if you go down that route trying to rush things. And so, needless to say, if you want 2 babies in our hands with euploid embryos, I recommend 1 embryo at a time in 1 uterus at a time, because that's going to increase your chances of having the family that you want with as little complications for both you and that surrogate. So that was one topic that I did want to cover. The other topic that I wanted to cover is the question about using frozen eggs versus having frozen eggs versus using fresh eggs. And so there's a lot of donor egg banks throughout the country, and it's a way that you can have a donor that's vetted, that's screened, they do their egg retrieval, they freeze their eggs, and now those eggs are available for use, whether it's a year from now, 10 years from now. We have pregnancies from frozen eggs and frozen embryos from decades ago. And so there's no adverse effect on the timing of that. But what we know is that an egg, though it's the largest cell in the human body, it is very susceptible to the effects of freezing, a lot more than embryos. When we have high quality embryos, about 99.9% of the time, they survive the freezing and thawing process. Whereas frozen eggs, it's a single cell. So only about 70 to 90% of those eggs survive the freezing and thawing process. And then the ones that are thawed, we find that they fertilize at a lower rate, and they create blastocysts at a lower rate than eggs that are fresh. So in our practice, we don't typically utilize frozen eggs. Now, if you are the person that froze your eggs when you're 35, and because now you're 45, you want to conceive with a new partner or any number of reasons, then of course, having 90% of your own eggs that were frozen 10 years ago is going to be the best opportunity for you to have your own biological child with the best chance of success. But if you're going to use a donor anyway, then we would much prefer using donor eggs that are fresh, because we know that the chances of success are going to be much, much higher. So, what other questions do we have? think we're having some audio difficulties. I'm not able to hear you. I'm not able to hear you. So one of the other questions while we're trying to get that situated that we had was regarding IVF and side effects. And so yes, yeah, there we go. So yes, there's a lot of side effects associated with in vitro fertilization stimulation, one of which is severe ovarian hyperstimulation, happens about 1 to 2% of the time. Typically what we do to help mitigate that is to watch your labs very closely, look for evidence of ascites, meaning fluid buildup in the abdomen. Two additional things that we do, we modify our treatment cycle to accommodate those patients that are at higher risk of ovarian hyperstimulation. We also give you medications orally to help mitigate the effects of the signaling that causes you to have those effects. And then finally, we recommend that during that cycle, you drink only electrolyte-rich fluids, at least for that week or two while you're in stimulation, meaning coconut water, Gatorade, Pedialyte, because drinking just regular free water is going to make you more dehydrated. And so doing that along the way, even before egg retrieval, is going to help the recovery after egg retrieval. Again, the high estrogen levels can delay your menstrual cycle after that IVF stimulation and egg retrieval. So don't fret about that. That's not anything that's going to be permanent. And then when we have egg retrieval and then it's time to do a frozen embryo transfer or ERA cycle, the in vitro receptivity assay, we check labs to ensure it's the right time in order to do that. Okay, what other questions do we have?
Yeah, sorry, Dr. Royster, I was on mute. But anyway, one of the questions coming from the WeChat a lot, I think what they try to say is that the pros and cons of anonymous egg donor versus non-donors.
Yeah, so there's definitely going to be pros and cons. So the easier one is that compensation is obviously going to be a little less for a directed donor because they charge you for their time and their effort. If it's an anonymous donor, then of course they need going through a lot of medications, effort, or to help you conceive. So that's one slight difference. The cost of IVF is already expensive enough. Added those costs, that can be a significant. The other psychological and legal factors, I think, are more important. Like I was mentioning before, if it's a close family member, then that's somebody that you're close enough that you're willing to donate or receive eggs or sperm from them. And so most likely, just the fact that you did that doesn't mean that after that baby's born, you're going to sever all ties with that close family member. And so that's something that you have to take into account because you may save money today, but in 10 years and 20 years, when that child is asking about Uncle Johnny, then that could be something that you would want to address. And then again, we want you to talk to a fertility psychologist specifically about those implications, whether you're an anonymous donor or especially if you're a directed donor, so that we can deal with that. And then again, have the legal contracts in place so that parentage and all of the other protections for those intended parents are there, so that everything is squared away even before birth. Because the last thing you want is for the child to then come into the world, and then for that gestational carrier or that surrogate or that egg or sperm donor to then change their mind and say, "Ooh, I do want to be a part of that child's life. Ooh, I want to be recognized as their biological mother or father." So again, those are some of the basic advantages and disadvantages.
This one's a little bit. I think it's this one say, I had a surrogate. Well, but prior to this, I had a candidate I really liked. But she smoked marijuana before she applied to become a surrogate. But the clinics, strongly advised not to use the candidate, but she was saying, because it's marijuana is illegal in many United States, and we understand, it's harmful when you use it, during the pregnancy. But the question is, would you, would you accept a candidate who smoked marijuana for recreational use, but they made a commitment not to use it during the the surrogacy or pregnancy?
That's a good question. So Obviously, marijuana use during pregnancy is not going to be recommended. Rationale for why we pick egg donors and surrogates that don't have a drug history, because they have less propensity to use those drugs or medications during pregnancy. Because obviously that's not a guarantee. You can have someone that is right about their past drug use and then they can continue to use drugs. I think you can consider that candidate if they agree that they're not going to use marijuana during their pregnancy. Guess what? Maybe you can put in a contract that you're going to have either periodic or random drug screening, because we can screen that pregnant patient if they have metabolites of THC. If there is that question or that concern, then it's going to add on that additional lab testing for pregnancy.
And this one is specifically for the clinic, SCCRM clinic. I think that what they're trying to see if they come internationally, there's no insurance coverage. Do you guys offer all inclusive packages? That pretty much covers everything.
Yeah. So again, everything's kind of on a case-by-case basis because everybody gets individualized care. We don't have a cookie cutter that says you're going to start your medication on Monday, you're going to have your egg infusion 14 days later, you're going to have this embryo transfer at this other time. So guess what? Maybe you need an extra hysteroscopy, fibroid, whether it's in your uterus or in the surrogate uterus. We do highly recommend that they have an sensitivity assay, a mock transfer, because all these other factors are going to cost a little more money. And if you're a cash pay patient that's having to pay out of pocket, we would hate to give you a cost up front that doesn't include these other recommended things that we may not have anticipated on the front end. So we don't have package deals like that because of those additional things that may come up, but we're very upfront about what the fees are going to be. And again, one of the things that you can do is you can go to www.sart.org, start.org, and you can look at the IVF success rates. Because one of the things that we pride ourselves on is that we report to the CDC our pregnancy rates. We report, all of our IVF cases. And when you look at some of our competitors, they're not reporting a lot of their cases. They're reporting 2% of their cases. And their pregnancy rates, guess what? Even though they're reporting a small percentage, in essence, cherry picking what they report, the pregnancy rates for each age group is going to be 10 to 20% lower than what we have here at SoCal Fertility. And so our success speaks volumes about the care that you're getting from Dr. Anderson and I. And so we're not a bargain basement, program. You're going to get, high-end, state-of-the-art care with a lot of treatments that you may not be offered at other practices.
Absolutely. And Dr. Royster, that I guess the follow on with this is more of like my question is like SRT, it's more coming out, but when you're talking about the reporting protocol, so they don't actually require you to report all the cases, if you can.
So yeah, it's a very good point. So it's the similar factors when you're going to a plastic surgeon. You go to a plastic surgeon to get a breast augmentation. Guess what? That plastic surgeon may not actually be a plastic surgeon, maybe a general surgeon. They may not be board certified plastic surgeon, but they have the best prices for breast augmentation. And so you go to Dr. X to get your breast done. Most of the time, it probably works out okay. But if you dug a little deeper, you might find out they're not board certified. And so that's one factor with IVF providers. Very similar. You can have people that are either grandfathered in to do IVF types of treatments and they're not board certified. But what we find is that throughout the country, not all clinics, maybe 90% of clinics actually report their statistics to the Centers for Disease Control and to SART. And so when you're just looking for an IVF program on Google, it'll show you all the doctors that might be in your area that offer services. But if you go to SART.org to look at that clinic, and you see that that clinic is not listed, that's how you know they're not reporting their statistics. They're not having that extra scrutiny on what they're doing prospectively so that you know what you're getting when you see that provider. So it's not just looking at are they board certified, which Dr. Anderson and I are both double board certified in OBGYN, reproductive endocrinology and fertility. You want to know, is your doctor board certified and does that clinic to start in the CBC. So that's very important.
Okay, Dr. Arthur. This is another question. Coming from this is a female audience. She say I'm in my early 30s. I've had very low AMH, high FSH. Are they the only factors that would decide, my fertility?
Yeah, that's a good question. And so again, here in 2 weeks, I'm talking fertility 101, and I actually have a slide specifically looking at ovarian reserve testing. So for women, we have 4 factors that we look at for ovarian reserve. One is your age. So a woman in her young 30s has a very good chance of having good eggs if you get them. The other factor we look at is the FSH level, follicle stimulating hormone. That's a hormone that's secreted from the pituitary that signal the ovaries to produce follicles and produce hormone. Typically like to see that FSH level below 10. Second factor. Next factor is the anti-Mullerian hormone. That's a small glycoprotein that's released from the early follicle. It's stable throughout the month and it's not affected by birth control pills. Typically, we like to see that AMH above 2. For women that have AMHs below 1, that might be concerning for women that has diminished ovarian reserve. And then finally, the last factor that we look at, which we do here in a natural cycle, we want to look at an ultrasound image of the ovaries on day 3 of your menstrual cycle. We look at that antral follicle count. That's an ultrasound where we can see those follicles that are 2 to 9 millimeters in size, and we count them up. And typically for women, we know that that's the number of eggs that are available to be stimulated by medication that month. And that can give us an indication about how much medication we need, what medication we should use, and how many eggs that we expect at the end. So for that woman that's in her young 30s, she may have a low follicle count and may have diminished ovarian reserve, but if I get 3 to 5 eggs from a woman that's in her young 30s, that may be better than me getting 20 eggs from a woman that's 40. Like I was saying, between 40 and 42, maybe 1 in 20, 1 in 16 and 1 in 20 of your eggs are going to be chromosomally normal. And so for that older woman that produces 10 or 20 eggs, we would be lucky if we get 1 or 2 normal eggs or embryos from that batch. Just like for that woman that's in her young 30s, don't fret because the number one factor is your age. And if your age is on the younger side, then I'd much rather get 3 to 5 eggs from you at this age than to wait 10 years and get twice as many. But it's just one of many factors. Again, we take all 4 of those into account.
Okay. I think.
Oh, and by the way, the other thing about that, you're going to read a lot of things online about, ovarian rejuvenation, what you can do to improve your ovarian reserve. None of that works, unfortunately. There are things that you can do that won't hurt you, like acupuncture, that may increase blood flow to the ovaries. CoQ10 supplements can help you as well. But Chinese herbs, some of these other supplements, ovarian PRP, injections, again, these things are going to be very expensive and potentially could hurt your chances of having the best reserve of eggs possible. So just know there's no magic surgery or treatment or supplement that's going to reverse time. So we can invent time travel. We're not going to be able to rejuvenate those eggs to a younger state.
Got it. And actually, another one I was actually asking you, but just in general, supplement. Well, actually, 2 parts. One is whether it would help, with any kind of supplement or herbal supplement will help with ovarian, reserve. The other one is just during the IVF process. Well, is there any supplement that you would advise for any patient to take that would increase their chance of IVF success?
Again, take your prenatal vitamins with folic acid and DHA in it. You can consider CoQ10, consider acupuncture, but I would talk to us, the fertility specialist, about any additional supplements because our recommendation is typically going to be not to take it. In women use supplements, it's typically to boost end products, meaning estrogen or progesterone. It's them giving you exogenous hormones because they tested your hormones and saw your hormone levels were low. Remember, that's an end product of your ovarian function. And so to put in extra estrogen into your system, it's just going to suppress your ovarian function, just like a birth control pill. So yes, it can boost your your estrogen levels in your bloodstream. It can make you feel better, but it's going to reduce the function of your ovaries because it's related to your signaling coming from the ovaries and coming from the brain. And the effects of high estrogen levels or high progesterone levels in your system is going to suppress your brain's function to signal the ovaries to produce its own eggs. So typically those supplements are not going to be recommended. And then most of them are not FDA approved. So if you have a supplement X that says it has 10 milligrams of this special product, one pill might be 100 milligrams and another pill might be 0.01 milligrams. There's no consistency with the production of that medication when it's compounded like that. So that's the other factor, is that pill to pill, batch to batch, bottle to bottle, you're not sure of what you're getting because it's not FDA regulated.
Okay. And picking question from this platform, have a do you Ashley Nemura? This audience is asking that for SCCRM, do you normally work with surrogates in Southern California? Maybe I guess she was asking, is it only Southern California or from across?
We have surrogates from all over the country that are utilized. So we do sometimes utilize outside monitoring for some of the early testing, transfer cycles or URA cycles. Have those surrogates or the gestational carriers come to Newport Beach to have their final lab test, ultrasound, obviously.
Okay.
By no means are you limited to just surrogates in the local community, and reach out and have surrogates.
Got it. And another guest is asking, I think this is one of the most common asked questions, so the difference between 3-day and 5-day embryos.
It's a good question. Let me see if I can share my screen. Let me share my screen real quick, and that way we can talk about that. So here is a video showing an embryo being developed. Pronuclei here in the middle, that means it's fertilized with an egg and a sperm. And then within the first 3 days of development, it should divide 3 times, from 1 cell to 2, 2 to 4, and then about 4 to 8 cells. Each one of these cells on day 3 are exactly the same. They can be an identical twin. And when we're looking under the microscope, that's all the information we have, is how they look under the microscope, because it doesn't tell us about the genetics of that embryo. As that embryo develops from day 3 to day 5, it continues to develop, but then it starts to differentiate into the inner cell mass and the trophectoderm. So this cell collection here at about 4 o'clock is called the inner cell mass, and that's what's going to lead to the embryo itself. The layer on the outside is called the trophectoderm, and that is what's going to lead to the placenta and umbilical cord. When we do the biopsy on day 5 to 7, we're taking a laser to take about 5 to 7 cells from this outside layer to send it for genetic analysis. Because now we have differentiation of this embryo, and we can safely do that biopsy without injuring the embryo. And when we do that, give me 1 second. And when we do that biopsy, then we're able to identify those day 5 embryos that are genetically normal. Because think of it like a beauty contest. On day 3, we only have 8 cells. An adult human has like 14 trillion cells. So there's a lot of changes when you're going from 8 cells to even day 5, where you have maybe 200 to 400 cells. You have a lot more cells to grade. And so typically in the past, when culture media wasn't as good as it is today, and our ability to incubate these embryos and have them survive in culture 10 or 20 years ago was a lot more poor than it is today. We were doing a beauty contest on day 3 and transferring that embryo in that uterus on day 3. The issue is that day 3 embryos are typically still in the fallopian tube. So if I put that embryo in your uterus, the temperature, the pH, and the nutrition content in the uterus is different than what that embryo is normally exposed to on day 3. So that's one reason day 3 embryos don't do as well. The second reason is that we're putting in a lot of bad embryos, and we wouldn't know it because we didn't do genetic testing. That's why we would recommend having at least a day 5 embryo transfer and one that preferably has been genetically tested, so that we know that that embryo that we're putting in is genetically normal. Because 85% of the time, when IVF doesn't work, it's because the genetics of the embryo was abnormal. You're still muted. There you go.
Okay, thanks, Dr. Astor. And do we have more time for? Do you have more time to take on more questions, or?
Sure. If people want to tune in and hear me talk, then I don't mind.
Okay, and I think the next one they were asking. One second. How would I prepare the sperm if I were to make a surrogacy process? Yeah, that's a little bit word by word. Yes.
I'm not sure what they're talking about. So
I'm not.
yeah. So for men that are donating sperm, typically there are 3 recommendations. One is don't have any exposure to the adverse chemicals, binge drinking, smoking, marijuana use, radiation therapy, high heat. Those are things that we definitely want to avoid. The next thing that you typically want before providing a sample for semen analysis or to freeze, you want 2 to 4 days of sexual abstinence. We don't want you storing up that sperm for a whole month to try to give us the best sperm that you think is possible. Because what happens is the quality of that sperm, the motility of that sperm is going to degrade the longer that you abstain. So typically we recommend 48 to 72 hours of abstinence before contributing your sample. And then the last thing I recommend is, by all means, avoid any testosterone supplements. Supplements that you can get at Walgreens, GNC, can boost your T. You see all those commercials about low T, low testosterone levels, low T clinics. And guess what? Plenty of doctors would prescribe a man testosterone when they're talking about they have decreased libido, they have decreased energy, and oh, by the way, I'm trying to have a baby. That doctor is still going to give you testosterone. Remember what I told you about women having estrogen levels suppressing their ovarian function? That is true a million times over for men, because at the level of the testicle, the amount of testosterone that you need to drive sperm maturation and production is thousands of times higher than what you can ever take with a shot or a pill. And so what happens is if you take a shot of testosterone, your libido is going to be great, your energy level is going to be great, you're going to feel good. That's because your testosterone levels are sky high. But guess what? That means your brain is going to stop signaling the testicles to produce its own testosterone and produce its own LH and FSH. And so what happens is testicles can start to shrink and shrivel, and then their functionality can sometimes be permanently damaged for those men that are on testosterone supplements. So that's the final recommendation. If you're thinking about conceiving, thinking about donating sperm, do not take any testosterone supplements. Definitely talk to a fertility specialist about that. Because if you have low T levels and you're trying to donate sperm or have a baby, there are other therapies that we can recommend for you that can address both.
Got it. Yeah, thanks, Dr. Royster. And this one is it might have a little bit of jargon, so I'm gonna read it to you. So I've been cruising and blasting for I don't know if it's a male or female, cruising and blasting. I don't know if you get it. Cruising and blasting AAS for several years. Been using HCG for the past couple months, but no dice. I guess it's related, but do you understand any of the jargon? Cruising and blasting AAS for the past few years, but don't try to get. Okay, okay. I'm sorry, but this is one of the questions. I don't know what's a. And another one was asking, can you would you like to share, because some some of the audience saw your picture in the background where you have with President Obama. Would you like to share this? It's more of an anecdote, but would you like to share that with the audience?
Yeah, let me see. So,
yeah,
the president of years back, deployment in other locations, President Clinton and I, during one of the deployments and a time that I had a humanitarian relief after a hurricane in Central America, and helped organize our Air Force support for supplying water and food to hurricane victims in Guatemala, Nicaragua, El Salvador, and Honduras. So that was pretty cool. The second time I met President Clinton, and then met President Obama at the White House back. This is now in 2013. And so I had the honor of meeting him, speaking with him, and yeah, so I've had a blessed career and good times. I'm glad to have served my country and done my time, and even happier now to be retired.
Yeah, I think Dr. Royster, I'm kind of running out of time here, but you know, a lot of guests they still have tons of questions. But I think what I can do, you know, of course, everybody have more, you know, if you have more questions and you like to schedule a consultation, you know, fertility related, or you know, like Dr. Royster mentioned, there's many other webinars coming up, and you like to go to SCCRM website, or you simply want to schedule a consultation, go to the center of the screen, click on schedule now, to redirect you to the website. And if you on other platform where you can't click the button, or Facebook, YouTube, WeChat, etc., we you know, we have your information, so we will follow up with another email that will include the link for you to register, for you to sign up. Yeah, Dr. Royster, thanks for participating and for your time.
My pleasure. Thank you, everybody.
Thank you, service. Yes.
Learned a little something tonight. And the first Tuesday of every month at 6:30, I have a different topic and a different subject that I have a pre-webinar. So have those discussions remotely with this webinar platform. And obviously, in person, you can discuss your own personal single and same-sex relationship or heterosexual couple trying. Thank you again. Have a good night.
Thanks. Thank you. Bye.